Hi, my name is Elinor Nemlander and I'm a general practitioner at Academic Primary Healthcare Center in Stockholm.
And my name is Karina Schultz and I'm a specialist in dermatology at Karolinska University Hospital in Stockholm.
And we're going to talk about teledermatoscopy that has been successfully incorporated into the healthcare system of the Stockholm region in Sweden, serving a population of 2.4 million people across approximately 240 primary care units. In this presentation, we will provide an overview of the implementation process and workflow of teledermatoscopy. We have no conflicts of interest to declare. So how does teledermatoscopy work at a primary healthcare center? As a GP, if I encounter a suspicious skin lesion on my patient, or if I'm uncertain about a skin lesion, I can create a referral within the patient's medical record. I can then securely log into a dedicated mobile, retrieve the referral I just sent, and capture pictures following a specific protocol, both from a distance and using dermatoscopy. I then send a referral with the pictures from the mobile for review. It is important to note that this process is not screening, but targeted assessment where I have a suspected skin lesion or if I'm uncertain. The dermatologist provides their response and recommendation within a week. And the response are documented in the patient's medical record. And it's really important that I will not only receive a provisional diagnosis and advice on further action, but also a description of the lesion from the dermatologist, which enhances my learning. The referral, the response, and the images are stored in the patient's medical record, allowing future review and analysis.
An overview, a close-up, and 2 dermatoscopic images, polarized and unpolarized, are uploaded in the mobile application together with background information. Relevant information includes age, gender, and the individual lesion's history. Primary care specialist is provided with a dermatoscopic description of the lesion with a preferential diagnosis and recommendation for management. A consultation report is issued by at least 2 dermatologists in consensus. If the lesion is unequivocally benign, no action beyond information to the patient is recommended. In equivocal flat lesions, a short-term digital dermatoscopic follow-up or excision may be recommended. If melanoma is suspected, the recommendation is an urgent excisional biopsy. The diagnostic excision is performed at the primary care clinic or, if necessary, referred to a surgeon or a dermatology clinic. We have noticed that primary care specialists in relatively short time shifting towards more difficult cases, which indicates a rapid learning curve. In every case, a detailed answer is written using pattern analysis as a framework. Primary care specialists acquire training in dermoscopy in structured response forms during their daily clinical practice. Double reading involving the co-assessment of cases is an important aspect in teledermatoscopy. Our experience indicates that the co-assessment of cases plays a central role as a training tool for new reviewers. It has helped us in recruiting additional team members and holds the potential to enhance sensitivity while reducing unnecessary excisions. During the double review process, 2 reviewers assess the case independently. They examine clinical and dermatoscopic images and provide a preliminary opinion, including a description for the dermatoscopic findings. In the case of any doubts or questions, the reviewers engage in a chat discussion until a consensus is reached. Finally, joint referral response is communicated to the referring physicians. All images and referral responses are accessible in the patient's electronic medical charts. Here is another example of referral for non-pigmented lesion.
The teledermatoscopy project was initiated with only 3 primary care centers from 2012. That was expanded to 10 centers in a regional funded pilot project from 2015. This allowed for testing of workflow and technology on a smaller scale. In 2017, a validation project was launched at 48 primary care centers to test the system on a larger scale. In November 2019, the Healthcare Administration decided to implement the system throughout the entire Stockholm region. And what was really important was that they made it a free utility for the healthcare providers. Because the question is, who should bear the costs? The major benefits of this system are for the patients and for the healthcare system as a whole, and not for individual healthcare providers. The significant advantages include fewer patient transfer between healthcare providers, enhanced safety with expert reviews and consultation, and reduced unnecessary surgeries, and the ability to review the case retrospectively in case of discrepancies in the pathology report. The procurement phase took place between 2020 and 2021, and the Dermicus teledermatoscopy platform was selected for implementation. In May 2021, the implementation of teledermatoscopy began with primary care centers gradually joining. A significant educational effort was required, which was accomplished through web-based training program and onboarding on the centers before joining. In March 2023, all 240 primary care centers in the region were connected, and we're now preparing for an active management organization. So how do you think it was to introduce new technology and new working method in all primary care centers in the Stockholm region, each with different operational models? Did everyone just stand around waiting for the baton and then started running? Well, engaging primary care, which is a service under significant pressure and high workload, was challenging. And the fact that we tested teledermatoscopy in both a pilot and a validation project allowed us to establish the right requirements in the procurement process and create confidence and support for an approach that works well in practice. We have also been able to monitor clinical effects of the method, which has brought the focus to what's important. Another strength has been that the system is both enjoyable and developmental for the physician at primary care centers. And having clinicians in the project group that also work clinically has been a major strength. We have a clear understanding of the realities. It has been challenging to align the contractual side because teledermatoscopy affects numerous healthcare agreements. And the success lies in maintaining a focus on the patient and ensuring that the best care for our patients. Another significant challenge that I don't think should be underestimated is to have up-to-date contact lists to the primary care centers and having people who respond promptly so you don't get stuck in telephone queues.
All primary care units in Stockholm are now using the platform. More than 1,500 referrals for suspected skin lesions are now sent monthly to Karolinska Hospital's Dermatology unit for review. We expect that there will be a fast increase of referrals in nearest future as the more recently introduced centers are now starting up and primary care is encouraged to use teledermatoscopy in the Swedish melanoma guidelines. General practitioners can submit all suspected skin lesions, whether pigmented or not, without any restrictions. Our main priority is melanocytic lesions, including equivocal nevi and melanoma, and they constitute the majority of the referrals. We also receive cases of keratinocyte-derived tumors like basal cell carcinoma and suspected squamous cell carcinoma. Additionally, a significant number of referrals involve benign keratosis, dermatofibromas, and vascular lesions. In 75% of cases, primary care specialists can provide reassurance to the patient without any further intervention. In 7% of referrals, excision is recommended based on suspected melanoma or when melanoma should be ruled out. Also, Spitz and Reed nevi in adults are excised. In 11% of cases, we recommend biopsy to rule out or confirm other skin malignancies such as keratinocytic tumors. In 7% of cases, follow-up is recommended due to nevi with a history of change or for equivocal lichen planus-like keratosis. In total, these last 2 years, we have had more than 14,000 referrals. More than half of dermatoscopically suspected melanomas in teledermatoscopy are confirmed as melanomas in histopathology. Equivocal nevi, for which we recommend excisional biopsy, are found to be melanoma in 10% of cases on histopathology. Less than 100 benign nevi, seborrheic keratosis, and dermatofibromas were excised, but none of them had histologically verified melanoma. We conducted a study to investigate the optimal utilization of the teledermatoscopy and compare the lead times for excision of malignant melanoma between teledermatoscopy and conventional electronic referrals. Overall, we observed that regardless of the pathway used, most excisions for highly suspected melanomas were performed within a time frame of 2 weeks. We observed that when teledermatoscopy was conducted during the initial visit upon noticing the lesion, followed by the excision in primary care, the lead times were significantly reduced. Teledermatoscopy should be easily accessible at the clinic and should be used during the same visit as the lesion is detected. Additionally, if excision is performed in primary care, the lead time to excision gets even shorter. We observed a trend in our study where thicker melanomas were found in the traditional referral group, while thinner melanomas and more in situ melanomas were detected in the teledermatoscopy group. This suggests that the combined use of dermatoscopy and teledermatoscopy could significantly improve early detection of melanoma, resulting in a higher rate of in situ melanomas and melanomas with lower Breslow thickness. It has been noted that dermatologists tend to identify thinner melanomas compared to non-dermatologists. By incorporating teledermatoscopy in primary care, it allows for dermatologists' evaluation during the initial visit, providing direct access to specialists. Another possible factor at play is selection bias, where obvious melanomas are referred to specialists while teledermatoscopy is employed for more uncertain cases. This approach potentially reduces the number of unnecessary excisions performed for benign lesions.
Okay, so in conclusion, using teledermatoscopy, the highest competence and experience can be used during the patient's first visit to the primary care center through remote consultation. And this really accelerates the diagnostic process. It also facilitates direct scheduling of surgeries at the primary care center, reducing time to curative treatment. It also provides reassurance and security to our patients, reducing unnecessary waiting times and alleviates concerns. Teledermatoscopy is also a learning system that enhances knowledge both for primary care physicians, as myself, and to dermatologists. Last but not least, it reduces unnecessary surgeries conducted as a precautionary measure to be safe. and this avoids the displacement of other necessary care, conserving healthcare resources such as pathology assessment. And given that primary excision is the main curative treatment for melanomas, and these procedures are performed by GPs at primary care centers in Sweden, this is the only cancer that we potentially have the capacity to cure at a primary care center. Thank you for your attention and for giving us the opportunity to share our experience. If you have any questions, feel free to contact us. Thank you.